Liver is a metabolic organ. So it basically controls the entire metabolism of the human. Commonest cause nowadays is fatty liver. The other is chronic abuse of alcohol. Pakka, there's no other comorbidities. Everything is perfect. Then we do something called as a desensitization program, wherein his immune system is suppressed and then the transplantation happens. So the success rate is in our institute with Professor Rela's team. The success rate is quite good. It's beyond 1995. Body. Let's talk a little bit about the anatomy and physiology of liver so that people can understand exactly what it is. The liver is on the upper abdomen on the right side below the right costal margin, and it controls the entire metabolism. You have two lobes of the liver, it's called as the left lobe and the right lobe, and you have the gallbladder attached to it. So the bile is produced in the liver, and the bile comes to the gallbladder. The gallbladder absorbs the water from the bile, and the concentrated bile comes into the intestines. And the food comes, the pancreatic juice, the acid from the stomach, all these things aids in digestion of the food, whatever we take. So there are conditions which causes these liver failures. And the commonest cause nowadays is fatty liver. They call it as NASH, non-alcoholic steatohepatitis. That is right now one of the very leading causes of liver failure in the adults. The other is chronic abuse of alcohol. You have viruses like hepatitis B, C, E sometimes. All these things cause liver failure. Certain medications people inadvertently take some Ayurveda or Siddha drug without knowing the compositions of what they are. So they can also lead to liver failure. Autoimmune conditions. There are other viruses called as Epstein-Barr virus or cytomegalovirus. These things can cause another condition called as Budd-Chiari syndrome, wherein the hepatic veins, it's all very small veins gets blocked, causing into liver failure. So these are the main causes of liver failure in our and paracetamol poisoning. Paracetamol poisoning. So drugs. These are the many common causes of liver failure in our.
Whether whatever is the reason for the failure, do they present in the same way when they come to see you? And what are some of the signals that people can watch out for, which can indicate a liver failure in the patient?
See, it's divided into two things. One is called as the acute liver failure. The other is called as a chronic liver failure. Patients present with two different symptoms. So history is very important. So history wise, we ask them whether they are taking alcohol for a long number of years, and you can make them from a sedentary lifestyle, and whether they are obese, for fatty liver. And in case if they had jaundice priorly, they might say they had jaundice couple of years ago. So they might not be aware of why the jaundice happened. So it might have been because of a hepatitis B or C virus. And at that point of time, it would have got cured. But the viruses will be lingering in the body, in the liver, leading to a liver failure. So usually the history is quite very important. And sometimes these people might have been taking some drugs, Siddha drug or Ayurveda drug, without knowing the composition. They might have been taking it for some joint pain or whatever, for constipation or whatever, for a long number of years. So these drugs can also cause liver failure in the long run, liver damage in the long run. So the common symptoms with which the patient present to us is loss of appetite, and initially they can be a loss of weight, and then progressively they can put on weight because of the accumulation of fluid in the body. The fluid can get accumulated in the abdomen predominantly. It can get accumulated in the lower limbs and also around the chest. Some patients can have a bleeding episode. They complain of passing dark, tarry stools, and certain people can also present with fresh bleeding in their stools. They can also present with vomiting, and blood in the vomitus. So it can progress until they can go in for something called as an encephalopathy, wherein they become comatose and they can have tremors, the flapping tremors in their hands. So they'll present with jaundice, icterus. They can present with high colored urine. The sclera of the eye will be yellowish in color. They can have myalgia, body pain, and diffuse body pain can be there. So these are the common symptoms they present with. The skins, the nail can be brittle. The skin will become quite dry. The hair fall can happen. The brittle hairs. All these things are again signs of liver disease. We need to thoroughly investigate the patient. We need to do the liver function test, which is a blood test. And then along with this, there's something called as PTT, INR, the international normalized ratio, those things. Then serum electrolytes, we do an ultrasound of the abdomen, an endoscopy, all these things. There are a gamut of investigations that need to be done. So with this investigations in hand, there is a scoring system called as a child's PUG score. And you have child A, B, and C. And there's something else called as a MELD score, a model for end-stage liver disease. So usually we go by the child score. Child A, patients can be treated with medicine. Child C, transplant is indicated. Child B, upper limit. Again, transplant will be indicated. The lower limit of child B, probably you can manage them with medications. The initial stage of child B can be managed conservatively, but the later stage of child B, transplant will be indicated. And there's something as refractory ascites. There'll be a lot of fluid accumulation in the abdomen or in the lungs, surrounding the lung, in the pleural cavity, wherein we need to take out the fluid repeatedly. So the other condition is when people are already in comatose encephalopathy. The other condition is a patient keeps on bleeding. So they might have done an endoscopy and they might have banned the bleeding vessels. But after some time, again, they'll be bleeding. So repetitive bleeding, all these things are a clear-cut indication for a transplant. We do a CT scan once in 6 months or 9 months, and probably an MRI of the liver also to see if there's any change in the liver. Sometimes a tumor can come in the liver on the background of a cirrhosis. In case if a tumor is there, then obviously we need to consider transplant at the earliest.
If the patient and the family has been advised transplant, what are the first few steps that they should take?
Medical gastroenterologist will guide you exactly what to do and what not to do, and they will do all the basic investigations and like endoscopy, CT, all the blood tests, all these things they'll be doing. But once the disease starts to progress and they're not responding very well to the treatment, it is better that they see a hepatologist or a liver transplant team and take it forward.
What is done during that process? How does it help the hospital and the patient?
Yeah. See, the pre-assessment is done. Probably the patient will be admitted for some 4 or 5 days. And not only the liver will be checked, the entire person, the entire patient as such, all the organs, like for example, the liver, how well the liver is functioning, because many a time these patients can go in for something called as a hepatorenal syndrome, wherein because of the liver, the kidneys can also go in for a failure. Something called as a hepatopulmonary syndrome. That is because of the liver, the lungs can get affected. And we need to look at the status of the heart, if there's any diabetes or hypertension or any comorbid conditions, whether they are all under control, so that we do all the investigations. For example, an echo, treadmill might be done, and sometimes an angiogram can be done of the heart to see, because liver transplant is a major surgery. So we don't want any surprises. So we do check the heart probably to the level of an angiogram to see if there's any blockage or anything. And once the entire stress test will be done for the heart, stress thallium tests, these kind of an echo, a bubble echo will be done. So all these tests will be done in 3 or 4 days time. And a psychologist, a neurophysician, a urologist, a colonoscopy will be done. All the specialists will be seeing this patient, and then they'll be giving us the fitness. Like the dentist also will be saying if there's any nidus of infection in the teeth, you know, because after the surgery, the patient will be put on immunosuppressive drugs. So this immunosuppressive drugs can enhance infections. And if there's an already tooth that is infected is there and we're not taking care of it, we don't want that infection to affect his liver post-operatively. So he might have a diabetic foot. The diabetic foot can be infected. So after the surgery, we don't want the infection from the diabetic foot to affect the new organ that has been transplanted. So in view of all these things, the patient will be looked in total by all the physicians, and then they'll be giving us the fitness for surgery. And once we obtain the fitness for surgery, which means the patient is ready. But then it's all dynamic. These things keeps changing every day. The electrolyte imbalances can tilt a balance, So these key things keeps changing almost on a daily basis. But then we can't do investigations on an everyday basis, obviously. So in case of anything serious thing, then obviously that will be looked into it.
As you rightly mentioned, some very dynamic, situation changes every moment. Typically, the major tests that are done in pre-assessment, what is the thumb rule that they are valid for before the patient needs to undergo a complete evaluation again?
See, the liver disease itself is something called as a waxing and waning. They have an uphill. They become really good, and suddenly they deteriorate. And again, suddenly they start improving well, and then they suddenly deteriorate. So it's called as a waxing and waning. See, usually the investigations are valid for a month, but then we can't see. For example, a colonoscopy, which is a normal study, need not be repeated for the next 6 months. Certain dynamic things, like for example, the heart is dynamic. So a heart echo or an ECG will be done once in a month. Certain blood tests need not be repeated. But a liver function test keeps changing according to the liver ailment. The INR keeps changing, electrolyte keeps changing. So these kind of things need to be repeated as and when required. But other tests, for example, a PFT or a colonoscopy, all these things need not be repeated very often. For example, a CT scan need not be repeated that very often.
Sir, are there any red flags in the assessment which makes the patient outright ineligible for transplant?
See, the term red flag is normally used in a liver transplant scenario when a patient is urgently requires a liver transplant. There are conditions, for example, when the patient presents with an acute liver failure. For an acute liver failure, there's something called as a red flagging. We do a red flag wherein any organ that comes they'll be switching the turns, and that particular organ will be allocated to this particular individual because they are present with the acute liver failure. The acute liver failure happens probably because of an drug patient didn't know. For example, this rat killer poison. There are many instances wherein children have taken this rat killer medicine thinking it is a water or honey or something like that, and so this will have an acute liver failure. You do a liver transplant post-operatively or a primary non-functioning graft. So you do a liver transplant. For some reason, this graft is not even working for some reason. So the hepatic artery is gone for thrombosis. So all these things you can have you can flag a red flag. Okay, factors ineligible. Assuming there is a tumor in the background of cirrhosis, and assuming that tumor has spread to other organs, then naturally it becomes ineligible. And even nowadays, there are instances wherein both are combined. But imagine there is a patient has got a cirrhosis of the liver and patient has got a tumor elsewhere. And that is already not under control. Again, there's no point doing a liver transplant. These are the other conditions wherein other organs are involved, wherein they can't be cured. So at that point of time, liver transplant may not be worthwhile. When you have other organs which is failing and it can't be cured either. See, if there's something called as a pre-renal condition, the kidneys have just started to fail. So if it is a pre-renal condition, we can do the liver transplant first and then wait for some time to see if the kidneys are picking up. If the kidneys are picking up, well and good. If the kidneys are not picking up and then the creatinine keeps on increasing, the urine outputs keep dipping, then again we need to consider for a kidney transplant separately. Age is just a number. So there are patients who are probably 70 years old or 75 years old. They'll be very fit. There are individuals who may be just 50 years old but may not be fit at all. So in case if the patient is 70 years old, and if we go through the performance index of the patient rather than a number called as an age, the performance status of the patient. If the patient is the performance index is very good, they are up and about agile, and psychologically they are very strong, and there are no other comorbid conditions, then we can still go ahead with an elderly age group patients. It's not that 65 is a cutoff. See, as you rightly said, there are two types of donors. One is a cadaveric donor, the other is a live donor. Cadaveric donor means it's it's the donor organ comes from a brain dead individual. They're not dead yet. They're definitely not dead yet. They are only brain dead. Once you're brain dead, in couple of hours or days, eventually they die. But before the blood supply, the perfusion to the organs go, we need to harvest the organs. So we can't afford to harvest a liver or a kidney once the perfusion shuts off. Once the blood supply is cut off to that organ, then I'm going to retrieve the organ. That doesn't make any sense. That's of no use. So we need to harvest the organs before the perfusion stops, before the blood supply to these organs stop. So the brain dead individuals are the ones from which the organs are retrieved when the heart is well functioning for them. When the heart is well functioning and when the heart is pumping the blood to all the other organs, we retrieve the organs. So that is called as the brain dead individuals. Live transplant is from live individuals. The liver, as I told you, has got two lobes, the left and the right lobe. So usually the right lobe is taken. But in children, even a segment of the liver can be taken. The liver has got 8 segments. The speciality of the liver is even a small segment can be harvested and transplanted to a baby. In fact, Professor Rela, Mohammed Rela, they have done he's got a Guinness record for performing on a 5-day baby. He just transplanted a segment of the liver from the mother and transplanted to a 5-day baby, and the child is now 28 years or whatever, and she's absolutely healthy. So from the live, for that, even from a cadaveric transplant, the two lobes can be separated and individually transplanted to two different children. It depends upon the body weight of the recipient. So in a live transplant, it's a controlled environment. It's a controlled environment because it is a planned procedure. So we know we are going to do a transplant now, and we need to check whether this patient's liver is fitting into the recipient. So for the live relatives, it should be a blood relative and it should be a proven relative. It's mostly it'll be like grade 1 and grade 2 relatives. So wherein we analyze the donor's liver, he should be less than 50 years of age. There should be no comorbidities. He should not have any other disease. He should not be an alcoholic or a diabetic or an hypertensive or things like that. So we have to match the blood group, whether it's A and A, like that. There are many instances we have done across the blood group also. When matching a recipient donor is not there, assuming the father is A group and assuming the son is B group, still we can do it. Still we can transplant. It is called as the complete mismatch across the blood group transplants. All these things have been done. Even in our institution, we do that routinely, and the success rate is also quite good for that also. But anyway, so coming back to the point, usually the blood group should be matching. So liver function test should be normal. No viruses should be present, and we see the anatomy of the liver, the blood supply of the liver, and we calculate there's something called as a functional liver reserve. What is the amount of liver that can be taken and transplanted to the patient, and what is the amount of liver that will be retained back to the prime most importance will be towards the donor. There's nothing should happen to the donor. So the functional liver reserve and the amount of liver that is retained back to the donor should suffice for him to be alive. But whatever amount of liver that is taken will regrow back in 3 weeks' time. 80%. For example, we are taking 100 grams. For example, I'm telling you, if you're taking 100 grams, 80% of the 100 grams will regrow in 3 weeks' time to the donor. So whatever liver that we are removing should suffice the recipient. This is calculated according to the body weight of the patient.
Sir, as you rightly mentioned, the focus, nothing should happen to the donor.
Yeah.
What are short-term risks?
So see the two calculation. One is called as the GRWR, graft versus weight ratio, and the functional liver reserve (FLR). So these two things should match. The liver that we're taking should match the recipient, and the liver that is retained back should match the donor. Right. So these GRWR and FLR should match properly. And there are various calculations, and according to the calculations only, we proceed with the transplant.
So, what are the risks, short-term and long-term risks that the donor can potentially face, and what's the broad outlook from a life expectancy or quality of life perspective?
See, if everything goes well, the donor will have a normal lifestyle, normal age, and normal lifestyle. So there's nothing will go wrong. But there are definitely complications that can happen. One is small for size. If you remove too much of the liver from the donor, he will have a small for weight, isn't it? And he can go in for a liver failure. So those calculations are quite important. Then there will be some kind of a bile leak when you are transecting the liver. There can be some kind of a bile leak that is coming, and bleeding can happen. So hematoma can form, and that can get infected. So infection can come, a bleeding hemorrhage can happen, and bile leaks can happen. So these three are the common side effects that can happen for the donor.
So, what is the timeline in which, let's say, there is no untoward incident which happened during the procedure or during the recovery? Typically, in how many months or how many weeks' time the donor would be as good as before?
Yeah. See, normally the donor are discharged from the hospital in 5 days' time. So, in 5 days' time, normally the donors are discharged. And as I told you, in 3 weeks' time, the liver, 80% of the liver that he donated will regrow back to him. And usually on the 10th day, we remove the stitches. And he can be up and about into his normal life from the second week itself. There's no problem with it.
So, you mentioned about, who can donate, because that's a very important question when it comes to any organ donation. There are government rules, around it. In your practice, sir, whom have you seen as the most common donors? And for education of our viewers, some other people who are eligible for donor, they might be first degree or second degree relatives, but they don't commonly either are not aware or they do not come forward. So if you can help list a few of the common relations or relatives whom you see donating liver for the patient.
Yeah. See, there are very stringent rules in India, like for transplants. Though they say any person who's emotionally connected can donate. If you look at the law book, it will say any person who's emotionally connected can donate, which means a friend can also donate, or a maid, or a worker who's been working with them for a long number of years. Out of gratitude, they can donate many things. But the rule says emotionally connected. But then it's got a lot of fallacies in it. So for all practical purposes, we'll stick to the point that they should be a proven relative. Usually the first degree and the second degree relatives. In the normal setup, it will be the parents who come for example, if it's a child, usually the mother comes forward to donate. And sometimes the father comes, siblings, brother, sister, cousins, first degree cousins or second degree cousins. So sister, brother. So these are the commonest people who can donate. As I did tell you earlier, the age group should be less than 50 and less, preferably the same blood group, and they should be devoid of any comorbidities. They should not have any big ailment. So these are the donation criteria.
Is there any best practice related to gender as well, that it's better to have a female donating for a female?
Not really. There's no gender bias on donations.
Right. And sir, coming to the cadaveric, because typically again.
Yes. So you were asking about the difference. See, when it comes to a cadaver organ, you are having a whole organ. That's the most important point. You have a whole organ for a transplantation. Whereas if it is a live transplant, you're only removing half of the liver, a portion of the liver. Assuming this patient is 110 kg, assuming the recipient is 110 kg. So you will not be able to find half of the liver that will suffice his weight. So at that point of time, we can't choose a live transplant at all for him because this guy is already huge. So only a whole liver will be good for him. And technically speaking, doing a cadaver transplant is much simpler when compared to a live transplant. So the volume of the liver is important.
But typically in India, we see that we are always deficit on cadaveric organ donation. What is your recommendation? Wait for cadaveric transplant or they should go for live transplant? What is that decision point?
Yes. See, in our country, still the organ donation awareness is not there. For example, in countries like Spain, the number of organ donations are huge. So it is, opt out, which means invariably the organ belongs to the state. Opt out means they have to have a card that they're not willing to donate the organ. If not, automatically the organ belongs to the state. So anybody who's brain dead, the organs are harvested and given to the needy patients. But in other countries, it is opt-in. You have to say that I want to donate the organ. There are nowadays organ donation cards are available. All you have to do is you just fill in the organ donation card. It's a very small card that you can keep it in your wallet, and it'll be signed by a witness. And you are saying that I'm willing to donate my organ. You are declaring that I want to donate my organs. Like that, and you can have it in the pocket. By God unwilling, in case anything untoward happens and that particular person becomes brain dead, when people can know that okay, he's already expressed his wish to donate the organs. So so that is one thing. And as you said, the awareness for organ donation is very very less in our country. That is why there's a huge dearth. So invariably, 99% of the people will not get an organ because the waiting period is so huge. Invariably, they'll not get an organ. So it is always better to pursue for a live transplant in case if they have a suitable donor. So if the live donors are exhausted, there is no live donor in their family, then there's no other option excepting to enroll themselves in the cadaveric program. If not, it is always better to do the live transplant.
But it's a question on the ABO blood group. You told that even different blood group can donate. Can you share more details around it?
Yeah. See, it is called as a ABO incompatible blood group, complete mismatch, or a partial mismatch. For example, a recipient is AB and the donor is A. The A component is there in the AB. So it comes as a partial mismatch. It is the recipient is A and the donor is B. Then it is a complete mismatch. These kind of situations when all the other things work out. For example, the GRWR is fine, the FLR is fine, the anatomy of the liver is fine, and the donor is pakka, there's no other comorbidities, everything is perfect. Then we do something called as a desensitization program. So wherein the recipient is admitted 3 or 4 weeks prior to the surgery, the desensitization program is carried on, wherein his immune system is suppressed, and then the transplantation happens. So the success rate is in our institute with Professor Rela's team. The success rate is quite good. It's beyond 90-95%.
Yeah, I think this is a common knowledge as a layman which we always carry, that only same blood group matching is very important. I think this is very insightful, that even people relative first degree or second degree relative with a different blood group can also become eligible to donate after evaluation. So coming to Chennai as a city has become a kind of hub for liver transplant. What is driving this numbers and the success in Chennai city?
See, Madras has always been one of the four major metropolitan cities in India ever since the British time, and it's well connected. You have a very olden day airport here, which means the flights have been coming in and flying out for many years, and you have a port, and in India, Madras has always been the leader in healthcare. You had the major corporates started only from here. Corporate setups started from here, and many stalwarts, the doctors, many stalwarts, be it cardiac surgeons or be it liver surgeons. In fact, the first liver transplant in a government setup in India was done here. The major orthopedic surgeries. Madras has always been a hub for medical tourism here, and now there are many hospitals here which are well equipped to perform very complex surgeries like liver transplants here. And the expertise, and people have gone to foreign countries, like for example, they've been trained in England for transplant, they've been trained in USA for transplant. So they all go abroad, get themselves trained. They've been to Korea, to Japan, and all these places, and they get trained themselves very well, and they come back to serve the population over here.
Sir, from a patient perspective, because today the second opinion is not restricted to second opinion, it has become multiple opinions.
Yeah. Can I tell you one more point? Among all the states in India, Tamil Nadu has the highest number of donations for many years at a stretch. So the awareness of organ donation is actually more in Tamil Nadu when compared to other states. That is why the organ generation is more here. So since more organs are coming here, people from India tend to come to Madras to get themselves registered here in the various hospitals, because the number of organ donations are here is more.
That's from the cadaveric.
Yeah, from the cadaveric point of view.
So, building on that entire, Tamil Nadu transplant program, TransTan, what we know it as. Could you explain how does it work?
See, Transplant is the organization which controls the organ allocation across Tamil Nadu. They have segregated into North Zone, South Zone, West and East Zone, like that. So various hospitals get enrolled according to the city where they are. So, for example, in Madras, like that, Coimbatore, Tiruchi, Madurai, and all these places, they do liver transplants. So whichever zone they fall into, they come under that zone, either North Zone or South Zone, things like that. See, this rules keeps changing now and then. But today, the rule is, for example, for the kidneys, the rotation is based on the patient, the date of dialysis for the patient. When was the first date of dialysis? So, according to the date of dialysis, the organ is allocated. So, it is based on the patient. But for the liver, it is based on the hospital rotation. For example, there are 10 hospitals, 1 to 10. The organ that comes to a common pool comes to hospital 1, and that organ is given to the hospital 1. Then another second organ comes to the common pool. Then it comes to the hospital 2. So this hospital 1, which took the organ first, will come back to the last. So likewise, the organs go in for rotation according to the each hospital. In this, for example, AB is a very rare group. Many hospitals might not have a recipient for the AB. So, for example, the hospital waiting list number 3, an organ comes, AB comes to the third hospital. But this hospital does not have an AB recipient. So, this will switch to 4. So, the fourth hospital also doesn't have a AB recipient. Then it will switch to 5. But these people will be remaining there itself. The hospital will be remaining in the same place. There's a current rule now. Before they were going to be, because they didn't take it also, they used to go behind. But now they don't go behind. They remain in 3 itself.
So the right to decline or unable to serve has come in, where their ranking will remain the same.
Yes.
The order to receive.
Yes. Just because they don't have a suitable recipient, it does not mean that they have to go back. They still remain in the same place until they do the next transplant.
Because TransTan data, a lot of transparent data, it's available in the public. So there are a lot of hospitals which have, let's say, 50 patients registered, but there are other hospitals which have 5 patients registered for the waiting list. How do patients decide which hospital to go for? So if there are 3 to 4 things which you can highlight, patient should take into account when selecting the right center to get registered.
See, obviously, if an hospital has 50 patients waiting and another hospital has 5 patients waiting, it obviously shows many people are flocking to this particular hospital. And why people flock to that particular hospital? Because they do volumes of surgery and their success rate is very good. For example, in our institute under Professor Rela, so we roughly do around 250 transplants in a year. In this, 90, I should say 98% is all live transplants. And in fact, we have published data. Our success rate is 99%, 99.2% for the live transplants. So when people know our success rate is this huge and our numbers are this huge, obviously people flock to us, and our waiting period, our patient waiting list will be more in numbers. Whereas another hospital might not be doing that many volumes, so their waiting period will be less. But having said that, the cadaver transplant results are not bad across many hospitals, or not bad across many hospitals. The cadaver transplant results. But then, when people are waiting in our institution for many months and years, that is detrimental to the patient. I agree to that. That is why we promote live transplant in such situations.
And sir, is there any provision? Let's say a patient has registered for X hospital, and later the patient wants to, get himself or herself registered for a Y hospital. So, is there any transfer of patient possible through Transtan or between the hospitals?
It is definitely possible through the see, Transstan is everything so transparent now. Anybody can view any of the data. So if the patient wants to transfer from one hospital to the other, they have to give a requisition letter that they are wanting to get themselves transferred from hospital A to B. And in 3 days to 5 days time, the thing gets sorted out. They are eligible to go to the other.
And do they lose their precedence order or something?
See, obviously, from our hospital, if they move, their number goes off, isn't it? So their number goes away. But the reason why they're moving to another hospital is probably they'll be up in the waiting list. If this particular patient is number 20 in our place and 2 in their place, it is worthwhile for them. So they get transferred there. But again, if they come back, they will not be in 20, no. They'll again go back to 25 or 26 or whatever.
Patients will get added.
So for this only in abroad, there's something called as a MELD score, model for end stage liver disease. So the organs are allocated according to the MELD score. The more severe the MELD, the more sicker the patient is. So organ allocation happens according to the MELD score.
Sir, earlier in the conversation, you mentioned about red flag, where you told that someone with acute liver disease can be allocated the organ within the hospital. So let's say there are
not within the hospital. When you have a red flag, assuming a organ comes in the common pool, it should actually go to hospital number 3, but we are number 8, for example. This organ will be bypassed to 3, 4, 5, 6 and 7 and will be allocated to us because it is an emergency.
Okay. So, and how is this coordinated? Because this looks like a very complex decision making.
Yeah, so all these things are done by the Transtan, and they have an excellent team and very experienced people. They do a fabulous job. The Madras Transtan, I mean, the Tamil Nadu Transtan is a wonderful organization.
Always the first fire is that I should get a cadaveric liver. Best case scenario that you have seen a patient really waiting and getting in front of
it depends entirely on your luck. There's no merit in it. It depends entirely on your luck. So if you're lucky, see, for example, you are A group and you're already waiting for a 1 year time. And luckily, this hospital's turn is now. And you're A group. And your turn comes, an organ gets allocated, but it is B group. So we can't be giving it to you, isn't it? It'll only be given to a B group patient. Again, you're unlucky in that. But that waiting list number 1 guy in the B group gets lucky. He gets lucky, which means only one guy gets lucky in couple of months, probably in 6 months time. When one organ comes, only one person gets lucky, but there'll be 40 patients waiting. No, there is A, B, and O. Imagine 10 people are in each. Among this 40 people, patients, only one guy gets lucky in every 6 months.
So, but this embryo compatibility that we spoke about, isn't it applicable for cadaveric
No,
donation as well?
no.
It's not.
You can technically, I mean, in the sense, O is a universal donor. So the O can be given technically.
Okay.
But then the transplant rule doesn't say so. The transplant rule says O only can be given to O in a cadaveric transplant program. But in a live transplant, this O, since it's a universal donor, you can donate it. You can transplant in a live.
So liver transplant is not a battle, it's a war. It's an emotional war, it's a financial war. So for the patients who have been recommended liver transplant, what suggestions can you give to them when it comes to managing costs? And what does typically cost looks like from pre-transplant, during transplant, post-transplant? What is that the patient should be prepared for?
See, for a liver problem, it's not one-stop shop. Patients repetitively come back to the hospital. They might repetitively come back with upper GI bleed or lower GI bleed. Repetitively, they come back with refractory ascites. Multiple hospital admissions are necessary many times. As I told you, because of the vaccine and waning, they very frequently they get admitted. So obviously, costs are involved into it. For a transplant, for example, in Tamil Nadu, you have the Chief Minister's Insurance Scheme, wherein if you have a CM scheme card, the entire transplant is done with that card itself. The government funds it. I think they give some 18 lakhs or something like that, and it's a huge boon for underprivileged patients. For the other patients, I would recommend they take insurance, the normal insurance I'm talking about, other insurance. So this insurance will cover your packages costs. Now the cost of transplant has actually come down than what it was earlier times. So roughly around 18 to 23 lakhs, I think a transplant can be done. There's no difference of cost in our institution between a live transplant and a cadaveric transplant. It's just the same.
And sir, you know, how does the timeline look like for a patient? How long is the surgery like? What is the immediate post surgery recovery period and the longer recovery?
Yeah, when we are talking about a live transplant, the pre-assessment, you can take it as a week. I'm talking about a chronic liver disease. A chronic liver disease, the pre-assessment for both the donor and the recipient probably will take a week's time at the max. And then uh, if it is a father or mother, you no need to go to the DMS for an approval. If it is a second degree relative or something like that, a DME approval is necessary. So they have to go to the DME to get the approval. That will take another 10 days or, like that. And then once the approval is got, we can just proceed to the transplant the next day itself. The transplant, typically an uncomplicated, straight transplant, will probably take 6 hours to 7 hours to do, 6 to 8 hours probably. And then the donor will be discharged within 5 days. The recipient probably in a week's time to 10 days time. The recipient get discharged. But then they have to be with a constant follow-up with the hepatologist. They come twice a week. Once every 2 days, they come to see the hepatologist for 1 month time. And then every week for the next 1 month. And then they can go back to their native place.
And sir, what are the factors which can influence a successful transplant?
The operating team is very important. Their expertise is very important. As far as live transplant is concerned, the team is a very key factor.
Of course, end of day, patient is undergoing 6 to 7 hours of surgery. It has to be the operating team and the care team which will define the outcomes. Uh, and coming to patient has followed up properly, has went back to the hometown. How does a post-transplant life looks like for that particular individual? Is it any different from a normal person? What are some of the most common precautions you recommend for the patient?
See, nowadays after the advent of all these immunosuppressive drugs, their longevity can be very normal. Post-transplant can be very normal. The only precaution is they should be from infection. They should take care of themselves, not to go into a very crowded places, not revert back to the alcoholic habit, you know, eating habit, a regular exercise, not putting weight and again making this transplanted liver into a fatty liver. You know, they should not be doing that. So they should have a proper lifestyle, stay away from crowded places, and get not get indulged with any infectious areas, and follow the drug regimen properly. The immunosuppressive drugs, they'll be giving one or two drugs every day. They should be taking for lifelong. So these kind of drugs they should be taking without fail, and they can have a normal lifestyle, and normal.
Is there any final message for the patient and the family waiting for liver transplant?
Don't lose hope. In case if you have a life relative who can help you out, that's the best. Try to lead a very healthy lifestyle, exercise daily, and watch what you're eating. And don't lose hope. All the very best.
Thank you so much, sir, for joining us on today's Health Factor show. I'm going back much more educated. Some of the things were eye-opener, like the ABO blood grouping, which you mentioned, can benefit a lot of patients who are waiting for transplant. Thank you again, sir, for your time and for sharing of your entire practice for the last 20 years in a nutshell with us. This is going to benefit a lot of patients out there.
Thank you so much, Govind. Thank you for inviting me. It's my pleasure. Thank you so much.